AOSD is a nonfamilial, systemic autoinflammatory disorder similar to childhood-onset Still's disease, systemic-onset juvenile idiopathic arthritis. It is characterized by seronegative chronic polyarthritis, arthralgias in association with a systemic inflammatory illness including a characteristic fever, various transient rashes, and a neutrophilic leukocytosis. Childhood-onset Still's disease was initially described in 1897 by the English pathologist Sir George F. Still. The characteristic features of this illness were subsequently reported in adults, as detailed by Eric Bywaters in 1971. Patients tend to be young adults, 75% aged less than 35 years, who present with a prolonged course of nonspecific signs and symptoms. Patients aged up to 70 years have been reported. The most striking manifestations are severe arthralgias, arthritis, spiking high fevers, and transient rashes. A prodromal sore throat due to perichondritis of the cricothyroid cartilage can occur days to weeks before other symptoms in 70% of cases. These patients appear severely ill and have often received numerous courses of antibiotics for presumed infection, although cultures are negative. As many as 5% of patients being evaluated for fever of unknown origin may be diagnosed eventually with Still's disease. A few patients have had similar episodes of this illness as children. The classically described fever in AOSD typically starts suddenly and rapidly reaches as greater than or equal to 39 degrees Celsius. The fever generally occurs only once a day, usually in the late afternoon or early evening and lasts 2 to 4 hours. The fever occurs daily for over a week and typically longer. Characteristically, the patient's temperature returns to normal or below normal between fever spikes. This pattern is known as a quotidian fever. In 20% of cases, the patient may have an additional early morning spike, double quotidian fever. The differential of a double quotidian fever is limited to AOSD, Kala-Azar, mixed malarial infections, Kawasaki's disease, right-sided gonococcal or meningococcal endocarditis, and miliary tuberculosis, TB. Note that in up to 20% of cases of AOSD, the patient's temperature may not completely normalize between fever spikes. Although the rash is said to occur in the vast majority of patients with AOSD, it is often unappreciated and less specifically sought. The characteristic appearance is that of evanescent, salmon-colored, macular or maculopapular lesions that are nonpruritic. The rash is usually seen on the trunk, arms, legs, or areas of mechanical irritation such as tight clothing, beltline. Often, it is only seen when the patient is febrile. The rash can sometimes be elicited with heat, such as that produced by applying a hot towel or taking a hot bath or shower. Koebner phenomenon, i.e., the rash can be induced by rubbing the skin, is reported in approximately 40% of patients. Skin biopsies and immunofluorescence studies are non-diagnostic, showing dermal edema and a perivascular mononuclear cell infiltrate. The arthritis associated with AOSD may be overshadowed by the systemic features of the illness. It may not be present at the time of disease onset, may involve only a few joints, or be fleeting. With time, the arthritis frequently becomes polyarticular, affecting both small and large joints. The joints involved in descending order include knees, wrists, very common, ankles, elbows, proximal interphalangeal, shoulders, metacarpophalangeal, metatarsophalangeals, hips, distal interphalangeal, sacroiliac, and temporomandibular joints. Neck pain is seen in 50% cases. Arthrocentesis generally yields a class 2 inflammatory synovial fluid, mean 13,000 cells per microliter. And radiographs usually reveal soft tissue swelling, effusions, and occasionally periarticular osteoporosis. Joint erosions and/or fusion of the carpal bones 40%–50%, tarsal bones 20%, and cervical spine 10% may be seen, but are more common in children than adults. A destructive arthritis occurs in up to 20% to 25% of cases. Patients with the chronic articular presentation of AOSD will frequently have less intense fevers and typically lower ferritin levels. There is no diagnostic test for Still's disease. Rather, the diagnosis is one of exclusion, made in the setting of the proper clinical features and laboratory abnormalities and the absence of another explanation, such as infection or malignancy. Aldolase is frequently elevated, whereas creatine phosphokinase is normal. Aldolase elevation is due to liver inflammation. Procalcitonin can be elevated in AOSD even in the absence of infection. Yamaguchi classification criteria is the most commonly used for AOSD. 5 or more criteria, including 2 or more major criteria, yields a 96% sensitivity and 92% specificity to classify a patient as having AOSD. Major criteria: fever greater than 39 degrees Celsius for greater than 7 days. Arthralgias or arthritis is greater than or equal to 2 weeks. Characteristic rash. Leukocytosis is greater than or equal to 10,000 per microliter with is greater than or equal to 80% neutrophils. Minor criteria: sore throat, lymphadenopathy, hepatomegaly or splenomegaly, abnormal aminotransferase, negative rheumatoid factor and anti-nuclear antibody. Treatment. Mild disease occurs in 25% cases with fever, rash, and arthralgias. In these patients, NSAIDs, naproxen 500 mg/bid alone can adequately control AOSD. If symptoms are not controlled in 2 weeks, they are switched to low-dose prednisone, 0.5 mg per kilogram per day. Moderate disease. Patients who present with high fever, disabling arthritis, and mild internal organ involvement are started on high-dose prednisone, 1.0 mg per kilogram per day, immediately. If prednisone cannot be tapered to a low dose without disease recurrence, methotrexate is added for patients with predominant articular symptoms. There is little experience using any of the other disease-modifying antirheumatic drugs, DMARDs. Antimalarials, azathioprine, mycophenolate mofetil, leflunomide, cyclosporin. Sulfasalazine should probably be avoided owing to a high rate of side effects. Severe disease. Patients who present with life-threatening organ manifestations, liver necrosis, cardiac tamponade, MOS, RHL, DIC, are treated with pulsed methylprednisolone followed by high-dose prednisone and early use of biologic therapy. Resistant disease. Patients who have life-threatening presentations are patients who continue to require high-dose corticosteroids, greater than 20 mg per day, in spite of 2 months of therapy with methotrexate or another DMARD may benefit from therapy with one of the biologics. Patients with AOSD have high serum levels of TNF-alpha, IL-1, IL-6, and IL-18. Consequently, therapy that blocks one of these cytokines including anti-TNF therapy, IL-1 inhibitors, anakinra, canakinumab, rilonacept, and IL-6 inhibitors, tocilizumab, have induced remission in 70%–80% of AOSD patients. IL-1 inhibitors and tocilizumab are more effective than TNF inhibitors, especially for systemic manifestations.